Welcome. I'm Shelley Welty, and Tammy and I are looking forward to spending the next couple of hours with you today. Let me get you on the right slide here to start with. A good start. We'll start with just some brief introductions, and then we'll get into our topic today of ketamine-assisted psychotherapy. We'll be looking at the latest research, mechanisms of action, and best practices in clinical applications. As I said, I'm Shelley Welty. I worked for UCBT for a number of years and now have a private practice near Los Angeles where I specialize in trauma and complex PTSD, using primarily EMDR and somatic interventions, also ketamine-assisted psychotherapy. Tammy and I both, we actually met in IPI's certificate program in psychedelic assisted therapy and spent many months in that program together. I'll let Tammy introduce herself.
Hi, my name is Tammy Clouston. I am a licensed clinical social worker and supervisor in Austin, Texas. I work in a private practice setting. I specialize in trauma and complex trauma, mood and anxiety disorders in my practice, and in group therapy. I am the founder of a program that is holistic in nature that provides support for patients through therapy and other healthcare practitioners called Hara Health Center in Austin, Texas.
All right, I'm getting the message that we have the wrong kind of share going on. So let me see. Not right? Okay, we'll just go with slideshow. Still not? Huh. Let's try again.
There we go. All right, this presentation is an introduction to ketamine-assisted psychotherapy and is intended to provide an overview of the elements of ketamine-assisted psychotherapy. More comprehensive training should be undertaken prior to administering ketamine-assisted psychotherapy. Next, Shelley. Neither of today's presenters has any conflicts of interest or any commercial support regarding ketamine-assisted psychotherapy. Next.
Right. Today we're going to cover a number of different topics. We're going to look at the mechanism of action of ketamine in the brain. We're going to talk about the different elements of KAP, ketamine-assisted psychotherapy, including the different methods of administration. And I'll look at a number of different specific mental health disorders and the current research on the efficacy of ketamine in treating those. And then we'll spend a few minutes at the end looking at some information about training programs in case this is something that you would like to pursue in the future. So let's start with mechanism of action. And to start, I'd like to just cover some terminology to make sure that we are all on the same page as we use these different words. So sometimes ketamine is lumped into the bigger psychedelic term. Conventionally, psychedelics are understood to be, this is serotonin agonists. So psychedelics really encourage the production of more serotonin in the body. And this results in some of those sort of mystical, hallucinogenic, transpersonal experiences that we have heard about and are familiar with. Ketamine is a synthetic medicine that's used in mental health settings as a therapeutic intervention. It's also used in the medical setting as an anesthetic and analgesic. And ketamine, different from traditional psychedelics, works on the NMDA system. And I'll talk more about that in just a second. But just to show that ketamine is not really known to be a traditional psychedelic, even though it's lumped under that umbrella sometimes because it does, for some people, give that same sort of hallucinogenic and mystical experience. Ketamine-assisted psychotherapy is a form of therapy where ketamine is taken by a client in coordination with their therapist with the intention of addressing psychological issues. Generally now, when we say ketamine-assisted psychotherapy, it's most often understood that that's happening in a therapist's office or sometimes remotely with a client at home and the therapist working with them remotely. But sometimes it can be used as well to refer to IV sessions or intramuscular, where there's an injection, where a therapist may be present in those settings as well. So what exactly is ketamine? It was first produced in 1962 and as an anesthetic and was used for soldiers in the Vietnam War. It became FDA approved in 1970 and is currently on the World Health Organization's essential medication list. It's used as an anesthetic and an analgesic, and it's very safe, even for children. I've put at the bottom there in that banner, there's an article that if you just want a little more information about the history of ketamine and its use, this article gives a pretty concise summary of ketamine's history, if you're interested. Another interesting thing to keep in mind about ketamine is that it has a really short half-life. It's only about 2 to 4 hours, so its time in the body is fairly short, which is beneficial in some ways. So another thing about ketamine is that it comes in 2 enantiomers, and this just means mirror image versions, the R and the S versions. The S enantiomer is twice as potent as the R, and this enantiomer is known as esketamine or Spravato. It's an FDA-approved nasal spray that Tammy will talk more about as she discusses the different routes of administration. All other routes of administration, aside from Spravato, are what's called a racemic mixture of these 2 versions, where there's an equal amount of each. Okay, let's talk about what happens when ketamine gets into the brain. And I really like this image. Obviously, I took it straight out of the article so that you could see it. I think it's a nice visual summary of what's happening when we work with ketamine. So you'll see there on the upper left of the slide, that is ketamine. That's its molecular structure. And even though we don't know everything, obviously, about what's happening with ketamine in the brain, because we often don't know everything that's happening with medications, we know that ketamine itself is really active in the nervous system. And also, as it's broken down, many of its metabolites are also really active in their own way in the brain. So below ketamine there, that lower molecule is called norketamine. It's one of the primary metabolites of ketamine, and it's very active in working within the brain, in the nervous system, and may someday, there's been a lot of research done on that metabolite in particular, that it may someday be used separately as a form of antidepressant. We'll see. But in the center, I think this is just a nice representation of all the different neurotransmitter systems that are being affected by ketamine and its metabolites. Up in the upper part, the opioid system and the monoamine system, those would be serotonin and norepinephrine. We know less about ketamine's impact on them. I won't talk as much about those, but we know quite a bit about its impact on GABA, glutamate, and brain-derived neurotrophic factor. So I'll talk a little more at length about that. Like I mentioned earlier, ketamine acts on the NMDA system, on the there are receptor sites on nerve cells called NMDA receptors, and they love glutamate. So as glutamate is sent across nerve cells through the synapses, NMDA grabs them. It likes glutamate a lot. Glutamate is the primary excitatory neurotransmitter in the human brain. That means it turns on lots of activity in the brain. So keep that in mind. At the same time that these receptors are being blocked, which means they're not grabbing glutamate, GABA, what we know about GABA is that it inhibits glutamate production, transmission. And ketamine inhibits GABA activity. So the inhibitor is being inhibited, which allows more glutamate transmission. So you have NMDA receptors are being blocked, not able to grab glutamate. GABA is being inhibited, so glutamate is more able to move between nerve cells. And in the same neighborhood as NMDA receptors are receptors called AMPA receptors, and they also love glutamate. So it's a good day for the AMPA receptors, right? Because there's a lot of glutamate present. NMDA receptors have been blocked. And so AMPA receptors can grab all of this glutamate. There's just a surge of it, and they have more opportunity to grab more of that. When that happens and these receptors grab so much glutamate, some things start to change within the nerve cells. Part of that impacts serotonin and norepinephrine, and they help to produce and express more of this brain-derived neurotrophic factor. The surge in AMPA receptor activity with glutamate also increases the production and expression of BDNF. And BDNF's main role is to promote neuronal growth. So there are new nerve cells being produced, they're becoming active, and BDNF is really important in synaptic plasticity. And we love plasticity in the brain, right? We love nerve growth, we love plasticity because that leads to new learning, the possibility of new behaviors, cross talk within the brain, sharing insights. So this is really good news for us as therapists, because we know new neural pathways can be created when this happens. This is one of the most important things that we think is happening with ketamine, is this production and expression of BDNF and the new opportunities for learning. So you'll see on the outcomes, synaptic strength, that's one of the main things we're talking about. These nerve cells are growing their connections, so there's better communication, and that's really helpful in depression. So there's a decrease then in some of the depressive symptoms. And this happens quite rapidly. So I also really love this image, so I took it right from the article. And we're not going to look at all the fine print here. You can read that later. You'll get the slides. You can do all that on your own. But I just want to look at the four main highlights here, because I think it's really helpful for us to think about how ketamine can break into this cycle and be really helpful for people who are depressed. And particularly when we talk about treatment-resistant depression, people who have been depressed for a long period of time. So there's this cycle that gets set in place where there are chronic stressors, which could take place before a depressive episode. And, at some point, the depression itself becomes a stressor, but there are these chronic stressors that are in place, which lead to inflammation in the body. And that inflammation then encourages the release of toxic hormones and chemicals in the body and the brain. And then eventually that takes a toll on our brain. There's some neurodegeneration that happens over time. And so if we talk specifically about depression, someone who has been depressed for a fairly long period of time starts to experience the atrophy of these connections between brain cells. It's just not, the communication is not what it needs to be. And if you think about all the impacts of that on someone over time, there's just a lot more difficulty problem solving, thinking in healthy, productive ways, thinking in new ways. There's more difficulty regulating emotions. And so this atrophy that happens in the specifically the dendrites of the synapses then causes more stress because it's harder. It's harder to manage emotions. It's harder to think clearly, and that creates more stress. So the cycle just continues and gets worse, actually. And then here's where ketamine can break in. And I've inserted another picture that I really like because this shows really clearly how ketamine very quickly can act in the brain. So if you look at the top picture there, the baseline day 0, this picture is of nerve cells in mice, and the red arrows show dendritic spines, those connecting points in the nerve cells, and you see them. They're there, they're healthy. Then they started to inject these mice with the equivalent of cortisol, which is a stress hormone in the human body. And after 21 days of that, you can see those dendrites have disappeared. There's less connection within the brain cells. And the bottom picture is 24 hours then after injection with ketamine. Those blue arrows show the growth of dendritic spines again. And this is really, I mean, the sort of dramatic action of ketamine in producing new nerve cells can really intervene in this cycle and give people a new experience, help them to think differently and start behaving differently. And we know we'll talk about this throughout our talk, the action of ketamine tends to be short, usually 2 to 3 weeks before there's another, a need often for another infusion of ketamine. And so we want to really take advantage of that period where the brain is more plastic and receptive and able to use what we have to offer in therapy to stretch out those benefits.
All right, now we're going to talk about some of the elements of ketamine-assisted psychotherapy. So one of the most important things that we're going to talk about when we're talking about ketamine-assisted psychotherapy are the routes of administration. So when we're talking about routes of administration, basically what we're talking about is how does the medicine get into our bodies, okay? And basically there are 4 categories for routes of administration. The first category is IV ketamine or intravenous ketamine. And this can be tailored and customized to the patient. It's got 100% bioavailability. It typically involves 6 treatments of ketamine over 2 to 3 weeks. You're going to have 2 or 3 sessions a week. And then you have booster sessions every 4 to 6 weeks following that IV ketamine, the initial period. The second route of administration is nasal ketamine, S-ketamine, and that is FDA-approved brand name Spravato. There, generally, that's 12 treatments over 8 weeks, followed by treatment every 1 to 2 weeks. And nasal S-ketamine has 50% bioavailability. It's not as rapid acting and has a lower rate of response overall. Next, we have intramuscular. The dose can be adjusted, and you can increase the dose over the time that you're receiving treatments. Intramuscular ketamine is 95% bioavailable. It's a less controlled experience. Like with the IV ketamine, you can control the drip rate and you control how much medicine is going into the body. If the client is having a challenging time, you can slow it down, pull back the medicine. With intramuscular, it's simply not the case. Once it's in, it's in. You're going to do what you're going to do. The medicine's going to do what it's going to do. Okay. And then there's oral. Oral is actually broken down into two categories. We have troches and rapid dissolving tablets. Oral ketamine is 20% bioavailability generally, and the overall dose is quite limited. It requires very frequent dosing. And this information is directly from our IPI training with Dr. Megan Oxley and Sandhya Prasad. Next, Shelley. So in talking about the routes of administration, we kind of break those down further into two other categories. So they're going to be prescriber delivered categories, meaning that you're going to need to have a prescriber in the room to deliver the ketamine to the client, because we're going to be very clear ethically and legally to stay in our scope of practice. And since we are not medical providers, we are generally therapists. We're not going to be giving anybody IVs or giving anybody shots or giving any medications. And so then going back to the intravenous ketamine at 100% bioavailability and intramuscular at 95%. The ketamine that we're going to be working with more commonly with clients in ketamine-assisted psychotherapy is intranasal. And that can vary. Like I said, there's brand names Spravato ketamine, which is FDA approved, but there also can be compounded intranasal ketamine sprays. And that's where you're going to get some of the differences, the range in the bioavailability. And there's oral troches or rapid dissolving tablets, and those are going to be 17 to 29%. Generally, those are compounded as well. And that's why you're going to see a variance in the delivery of the medicine. Okay, next. So an important thing that we thought that we would point out to you all is that even though ketamine is FDA approved, there's a very limited FDA approval for mental health treatment. And this particular quote is taken straight from the FDA website, and it's from February 2022. So it speaks to legal and ethical considerations. And brand name Spravato is FDA approved for treatment-resistant depression, with stipulations that it be taken in office and that the patient be monitored for 2 hours. Ketamine is FDA approved in hospital settings only as an anesthetic, and for mental health disorders, it's considered off-label use. Compounded ketamine is not FDA approved. No compounded medications are FDA approved because the formulation is not controlled. And so then non-FDA approved medications are not covered by insurance. And that's an important thing to take into consideration with the populations that we serve. The FDA approved model does not explicitly demand therapist engagement and prep or integration. And Spravato actually falls under a certain category called the risk evaluation and mitigation strategy, because the risk for sedation, dissociation, respiratory depression, abuse, and misuse, Spravato is only available through a restricted program called the Spravato Risk Evaluation and Mitigation Strategy Program. Spravato can only be administered in healthcare settings certified in the Spravato REMS program. Patients treated in outpatient healthcare settings, such as medical offices and clinics, must be enrolled in the program. I think that's an important legal consideration. Next. So when talking about psychedelic experiences, it's important to differentiate that we have different levels of a psychedelic experience, okay? So the traditional psychedelic experience allows for states of consciousness beyond ego, and the client undergoes a full psychedelic experience with a lessened ability to talk during the experience. In a full psychedelic session or a full dose of ketamine for a psychedelic session, you're going to find that the client doesn't speak to you very much. If you've ever received ketamine session or an IV ketamine session, you'll be able to relate that the words don't come as easily under the influence of the medicine. And processing other people's words can be slower as well when you're under the influence of the medicine. So that's one category of experience. The next category is what we call the psycholytic experience. And in the psycholytic experience, the client isn't as deep into the medicine, and they have they can maintain their ego defenses, and they only undergo a partial psychedelic experience and can engage in conversation more freely and talk to you about what's happening in their experience and process with the therapist in the room or on screen during the experience. Now, there are also ketamine infusion, just classified as a pharmaceutical intervention. These are ketamine infusions that are happening in medical clinics all over the nation. And these experiences are happening often without a therapist in the room. There's no emphasis on the psychedelic experience, and the dose can be high enough to leave a client unable to speak with little memory of the psychedelic experience. That's not what we're going to be talking about here today. Right, next. So it's important to know about contraindications for ketamine for clients in order to encourage clients into safe treatment. We're going to talk about preparing clients for ketamine in just a little bit, but as we talk about contraindications, it's important to know that we're not going to treat clients that have any active psychosis or any active mania. I mean, some of those things kind of speak for itself. We're not going to take a person with psychosis and put them into a hallucinatory state. And we don't want to treat somebody that has active mania, because sometimes ketamine, very often ketamine will bring out a more manic behavior for a client in the time that they're in the medicine. Borderline personality disorder is a rule out for most psychedelics. The reason being that emotion regulation is a very important part of the psychedelic experience. Client needs to be able to manage and navigate through some really tough emotional experiences, or what can be very tough emotional experiences. Considering that this is actually, therapeutic work. Other contraindications are for clients that are taking Lamictal. Lamictal works on a glutamate receptor that's very similar to ketamine. And so if a person is taking Lamictal, we're going to ask them to hold that on the dosing day. The same would be true of any type of benzodiazepines, Xanax, Ativan, etc., and stimulants such as Adderall. We're going to hold those on the dosing day as well. Other contraindications, uncontrolled hypertension or other heart conditions, risk for stroke. Ketamine does increase your blood pressure. And so we're going to be very thoughtful about people who have cardiovascular conditions as we invite them to the ketamine-assisted psychotherapy process. Any active substance abuse is going to be a rule out. Just because we don't know what else is on board, we're not going to add ketamine when we don't know what else is on board. Obviously, pregnancy is going to be ruled out. We don't know the damages that can happen in utero. Sleep apnea, because of the depression of the respiratory system, we're going to rule out sleep apnea. Recent traumatic brain injury. Untreated seizure disorder is a rule out, because ketamine is a dissociative anesthetic, and anesthetics can lower the seizure threshold. And when we lower the seizure threshold, it creates greater opportunity for a person to experience a seizure. And so we're going to be cautious about that. And then recent eye surgery is another contraindication, just because of the increase in blood pressure and the way that the eyes experience the increase in blood pressure. Okay, next. Some of the side effects that will happen when a person is has taken ketamine, we want to be thoughtful of possible addiction issues that are still being researched. But the side effects that occur during treatment, but rarely happen in between treatments, are nausea or vomiting, hypertension or increased hypertension during the session. It usually returns to normal within 4 hours of treatment. Sometimes people can have unsupported, difficult experiences if they're doing ketamine sessions without a therapist present. Treatment emergent agitation or confusion again, with the dissociative anesthetic, we're going to have a little bit of an out-of-body experience, and so less connection to the body, and sometimes that can make people feel very agitated or fearful. And there can be also altered pain perceptions. Ketamine is often used to treat pain in hospital settings, and so people are not going to experience pain the same way under the influence of ketamine. Another side effect that occurs very often with IV ketamine is urinary urgency. Um, Basically, that means it's kind of difficult to pee after you've had a ketamine IV. And this is a condition they call cystitis that can make it difficult to pee. It usually abates within a few hours from having a ketamine experience. But sometimes people are a little bit freaked out when they try to go to the bathroom afterwards, after they got all these fluids, and then it's kind of hard to pee. Then some of the after effects. People should not drive. This would be in all the literature on ketamine-assisted psychotherapy. They're not allowed to drive until the next day because of motor coordination. Nausea can persist after a ketamine treatment. Sometimes the patients can report headaches or feeling fatigued. Very often people will report that they are very, very tired after a ketamine infusion or ketamine administration. Next. So there are some benefits of ketamine versus other psychedelics. Similar in experience to other psychedelics and usable when other psychedelics are not. And what we mean by that is that other psychedelics can be only available outside of the country, except for in Oregon and Colorado, and we'll talk about that. Other psychedelic therapies often take a full day. They can take 6 to 8 hours for other psychedelic experiences, and they can sometimes feel much more intense than the ketamine experience. Ketamine is broadly available and it's very inexpensive. It takes much less of a time commitment. When we're talking about ketamine-assisted psychotherapy sessions, we're talking about sessions, a client can be in the medicine for as little as 30 to 45 minutes, or they can come out of the medicine at like 90 minutes or 2 hours. It's processed and metabolized differently in different people's bodies. Ketamine supports a growth mindset. As Shelley had talked about, we've got the brain-derived neurotropic factor working for us, and so we're going to have we have a greater potential for learning and greater for potential for really taking the therapy components and growing from them with the new neural pathways. Often clients will naturally move towards topics that they've been stuck in when they're in a ketamine experience or any other psychedelic experience. Often this can be the thing that they set an intention around. It's like they've got this thing that they've been working on and they haven't really shifted it. And so that could be the thing that they want to focus on when they set intention for their session. And then it can have a new perspective to things with ketamine, and they can feel more open. The knowing can become more embodied in a person's ketamine experience once they're in the medicine. And that can feel like a relief for clients and can feel very supportive. Where we might find just in traditional therapies, people are more questioning the things that we're talking about in session. Next. So a big question that we get in these types of presentations is how do we as clinicians support our clients? And this is really for like clinicians that may know that their clients are going to do ketamine-assisted psychotherapy that they may not be sitting in, okay? And so it's really important for you as a clinician to communicate with the ketamine team if you're not on the ketamine team, and more if you are on the ketamine team, it's a good idea to communicate. It's important to receive your own training in supporting psychedelic therapy. And we're going to talk about that in length at the end of this presentation. use the openness and insights that the client brings from their ketamine sessions as a source for discussion. Explore with clients the things that they experienced and perceived in their ketamine journeys, and look at potential insights for clients. And that's a very important part of supporting the clients in this process. You can also support a client by helping them find footing in the psychedelic space. And let them know, that they're going to be working hard. Like, a lot of people, when they think about psychedelic assisted therapies, they think that that's going to be really fun. And often psychedelic assisted therapies are not fun. They can be difficult journeys, and they can be difficult emotions that are coming up, and they could be re-experiencing trauma, or like working on hard things, and they're going to need lots of support. And it's good to make sure that we're telling clients about these things. It's important for us to be very curious and affirming of the client's experience. And always encourage your client to have a deep relationship with their CAP provider, if that CAP provider is not you.
Tammy, we have a question from some of the rule outs that I'll bring up to you. If someone uses a CPAP machine during treatment, is sleep apnea not a rule out?
That's a great question, and one that I would probably, in my own practice, I would check with a prescriber on that. Anytime there's any kind of medical safety issues, I always default to the prescriber or the medical professional. I don't try to make those decisions myself. Again, sticking with scope of practice. Right. So since I'm not prescribing a CPAP machine and I'm not prescribing the medicine, I'm going to rest on the knowledge base of prescribers and the fully medical parts of this experience. Any other questions? All right. So now we're going to talk about other elements of CAP. As I just talked about, fortuitous timing, it's very important to have a good relationship with the prescriber or medical professionals while you're doing ketamine-assisted psychotherapy. I was fortunate enough to go through my training with a prescriber in my practice setting. And so we work very closely when talking about best practices for clients that want to pursue ketamine-assisted psychotherapy. There are basically, in every psychedelic experience, there are three components, and that is preparation, journey, and integration. And this slide kind of speaks to some of those things. With preparation, we're talking about things like informed consent. It's important that we're talking about and explaining to the client what a ketamine experience is going to look like and feel like, about what their role is as a client and our role is as a clinician. We're going to discuss what their expectations are from the journey. Like I said, sometimes clients are thinking that it's going to be great and fun and exciting, and very often it is not those things. It's not fun. It can be exciting as we're like incorporating new learning and new experiences and new insights. That can be exciting. One of the most important things that we're going to discuss in preparation is therapeutic touch. And we're going to talk about therapeutic touch different from safe touch. Okay. So therapeutic touch is like when a client is in the medicine and they need support, is it okay for me to come and, put my hand on your arm or your shoulder to comfort you, or to hold your hand if you're tearful for a very long time, or if you feel afraid. It's not uncommon that I'll have clients ask me to hold their hand, but we will always talk about these things ahead of time, because a client cannot give consent for therapeutic touch once they are in the medicine. And that's a very important legal distinction that we're going to have to make. Anytime anybody is under the influence of something, they cannot consent to treatment or to any other specifics. And so that's going to be a thing that you're going to discuss in preparation. Another type of touch that's important in preparation is to talk about safe touch. And safe touch is like if the client is doing something that could be dangerous for them, right? Very often when a person's in ketamine, they feel very heavy in their body. They're going to be kind of stuck to the couch. But sometimes that's like not the experience. Sometimes the client might get up or walk around. If a client needs to use the bathroom, we're going to have to go with them to go to the bathroom. And if they're going to step into something or, cause harm to themselves, then we might have to intervene. And that is what safe touch is. It's like making sure that the client is safe, kind of from their own selves and their impaired motor function while under the influence of the medicine and anything that comes up for them. So it's important during our preparation sessions to talk about all these things and to provide paperwork for the client because it's a lot of information. It's a very different experience, and making sure that the client has these things once they leave their preparation sessions and go home to come back and talk about with you. So the next thing that we're going to talk about is set and setting. And set and setting is the mindset of the client as they go into their ketamine-assisted psychotherapy session. It's like, what are they expecting to happen? How are they feeling about what's going to happen? Um, what are they wanting to work on, and how do they feel about all of those things? Those contribute to their mindset. It's important during any psychedelic session to set an intention for what you'd like to learn or focus on in your journey. Sometimes what your intention you set for a psychedelic journey is nothing that actually comes up. Sometimes it is, we never know what's going to happen. And so it's always good to try to guide the experience by setting an intention. Very often, if a client doesn't know how to set an intention or doesn't know what to work on, what I might gently encourage a client to do as a practitioner is to say, I'm just open to what needs to be healed now in my life. If I've had a client that's worked on quite a bit of their trauma or anything like that, and they're just wanting to have a ketamine experience and feel better. So those are things that we take into consideration when we're setting intention. This setting should include some basic safety components. In my office, some of the basic safety components, is having staff that's trained in first aid and CPR. In my office, I have nurse practitioners and physicians that are here in office. We have a defibrillator that we have access to should anything go wrong. We have oxygen available for the clients if they need it. Our prescribers will often have rescue medications for like anxiety. They might need to help a client if they're having an overwhelmingly anxious experience. And so a prescriber might give one of those things if you're doing a session with a client that has a lot of anxiety. The setting also needs to be comfortable. I mean, you have to take into consideration that a client's going to be laying down for 45 minutes to a couple of hours, right? And so, a safe couch, a comfortable couch, or a recliner. Very often, providers are using recliners so that the client can lay down and feel comfortable in the ketamine experience. Um, and then if a client is doing ketamine at home and you're working with them remotely, you want to make sure that they have a comfortable place that they're not going to be disturbed for their experience if they're at home. Again, keep in mind that the clients will not be able to drive themselves home after a ketamine experience. And so they have to have that organized before their session. Integration is the third component of any psychedelic experience. And in it, that's where the magic happens. A lot of people think the magic happens in the medicine, but as a therapist, I like to believe the magic happens in the integration. And the integration and the power of the integration is really where we get the most meaning and that we can get the most outcomes. So as we talked about, like, with the brain-derived neurotropic factor, we have neural pathways, and we have an opportunity to really have new growth and new learning in our experience. And integration is where this can really happen. And so, like, that can happen in the session the day of, or it can happen like very soon after. It can happen in the next day or a week from session. But we're really trying to make meaning of the things that came up. And if there are new beliefs that we are wanting to work with the client, now is the time to be really reinforcing those beliefs. Like if you're doing cognitive behavioral therapy and you're really working on a person's like lovability, like reinforcing those affirming statements in integration, you're going to have greater outcomes with that. And then safety for the clinician and the client is a really important element of CAP. It's important to know what your client's trauma is. It's important to know this for your safety as a clinician providing a psychedelic experience for somebody, and it's important for the client to understand how their trauma can be re-experienced in a psychedelic session or ketamine-assisted psychotherapy session. Because if we don't understand the trauma that our clients have experienced and how it can show up in a ketamine-assisted psychotherapy session, we can get ourselves into some murky water. We can get ourselves into situations where the client may have thought that they experienced something under the influence of medicine that they didn't experience because they were re-experiencing trauma and they weren't aware of that. And so it's really important that we are safe for the clients and for ourselves. And sometimes what that can look like is, having cameras in session to make sure that, there's video footage of all the things that happened in the session so that the client can be reassured after session that they're kept safe in all ways during the medicine experience. All right. So a lot of questions come up with how to know if your client is ready for psychedelic experiences or ketamine-assisted psychotherapy. And I found in our research, we found access to the psychedelic preparedness scale. And the psychedelic preparedness scale has like 20 questions that are really statements, and you would rate those statements and determine whether or not the client would rate these statements, and then you would make a determination if the client is ready for a psychedelic experience. Okay, and so the first category, they have 4 categories in determining psychedelic preparedness. The first is support and planning questions, and I'm going to read through some of these statements because I find that they're really important and like lay the groundwork for psychedelic experiences. So support and planning questions are things like, I had prepared some strategies in case things started to get difficult during the psychedelic experience. I had made a plan for what I would do in the hours and days after the psychedelic experience. My family and friends were prepared and well informed about the changes that could occur in me. I felt the substance would be safe to take. I felt a trusting and positive connection with the people who are going to be around me during the experience. So all of these things are talking about like the support around the client has around them and the way that they feel about the experience. Next. The next category in the psychedelic preparedness scale is intention and preparation. And the statements are, I engaged with specific preparation practice before the psychedelic experience. For example, I did meditation, yoga, breath work, journaling. I was conscientious about my diet and exercise. I spoke with a therapist or a counselor as part of my preparation for the psychedelic experience. I had carefully contemplated my reasons for taking a psychedelic substance. I had a clear intention for the psychedelic experience. I trusted my own mind and body to safely process the experience. Next. The next category is psychosocial readiness. I was prepared for the physical effects of the psychedelics. I felt psychologically prepared for the psychedelic experience. I felt ready to surrender to whatever the psychedelic experience would be. I was prepared to deal with uncomfortable and challenging aspects of the psychedelic experience. I was ready to experience whatever came up during the psychedelic experience. And then finally, knowledge and expectation is part of preparedness for psychedelic experiences. I was aware that the psychedelic experience might change me in some way. I knew that my experience would be somewhat unpredictable. I understand that events from my past I understand that events from my past could surface in the psychedelic experience. I understand that the experience could evoke a range of intense emotions from bliss to horror. I had done some of my own research into the effects of the psychedelic substance, reading articles, books, watching videos, and listening to podcasts about psychedelics. And so all of these things are things that we're going to cover with a client before making the recommendation for a client to participate in any psychedelic experience or ketamine-assisted psychotherapy session. Okay, next. So a big source of curiosity that I get from providers that are not ketamine-assisted psychotherapy providers are like, what does it look like? And this was the biggest question that I had before I became a psychedelic-assisted therapist. You know, like, we know what a talk therapy session would look like, or what an EMDR therapy session or CBT session would look like. But, once we introduce the medicine, it changes things and things will look very different. And so I included a picture of my office there. That's exactly what I'm looking at without the fun and funky lights today. But you can see a lot of the elements that are there in the photograph are things that are going to be present during a ketamine-assisted psychotherapy session. So very often when we're having a ketamine-assisted psychotherapy session, the space is going to look different. If we're having them with our regular clients, the space is going to look different than it does in a regular therapy session. So I'm going to greet the client and orient them to the space. I'm going to double check that the client has not eaten within a few hours of the session to discourage vomiting. But you can see there's a little vomit bag there just in case anything comes up. We're going to take their blood pressure and orient the client to the heart rate monitor and the O2 monitor. So there's a little heart rate monitor and O2 monitor on the floor there next to the couch. I have the clients wear those when they're in a CAP session with me because it's an indicator of what's going on inside for the client. Sometimes the client may not speak to me while they're in the medicine. And while they're in the medicine, if their heart rate spikes, it's a good indicator that they're working on something, that they're processing something important, right? That their heart rate is telling me what's going on for them. And so if I notice the client's heart rate is well above what it was when we started, I may take my cue to go and sit next to them and just be ready that, something could come up that they want to talk about. Same thing with the oxygen. If a client's oxygen goes down while they're in the medicine significantly, the monitor will beep and it'll tell me that the client's not getting enough oxygen. So I might come near the client and gently ask the client to take a deep breath and to coach them to take a deep breath because they could, again, be processing something difficult and maybe holding their breath. Okay. Before a client takes the medicine, I would ask the client if they have Zofran with them that was prescribed to them, if they have blood pressure medication prescribed with them, because very often if we take their blood pressure before we start a session, clients could be anxious and about what's going to happen in the medicine, and they might need to take their medicine before session. I would ask the client if they have those medications, and then I would remind them about therapeutic touch and touch for safety. And we would go over all those things and make sure that the client is feeling comfortable and has everything that they need before we would have the client take their medicine. So when the client takes the medicine and it's in session like this, very often what a client is taking is a troche or a rapid dissolving tablet. If the client is taking a troche, often I will have candy for the client because the troches taste absolutely horrible. They Clients will often not like the taste of it, and so they'll have the troches underneath their tongue, and then we'll have them put a piece of candy on top of their tongue, kind of like working with the taste buds so that they are diffusing the taste of the ketamine because it tastes awful. And then very often with the troches, we're going to have the clients like sit with the medicine in their mouth for a few minutes. It's generally recommended that they sit with the medicine in their mouth for about 15 minutes and then have them swallow or spit it out. Very often the clients will just swallow the medicine. And once the client starts to experience some numbness or tingling in their mouth, that's usually an indicator that the medicine is working for them. And when the medicine is working for them, we would have them, be sure to lie back and put on their eye shades, put on their headphones. This is to encourage an internal experience, an exploratory experience. We have curated playlists for ketamine. Usually the music is considered the second therapist in the room. The music will have, it's not going to be the music that you're going to hear on the radio. There's no Taylor Swift going in these ketamine sessions. It's going to be music that can be very spiritual in nature, usually with lyrics that are not in the language that the client understands, to encourage that internal experience or that internal process. And so those are elements that we will have in the ketamine-assisted psychotherapy session. I have an ottoman in my office that is close to the couch. I will often make sure that the ottoman is moved out from the couch enough that I can sit comfortably on the floor next to the client if they're on the couch. And I would do that before they take the medicine, just to make sure that if anything happens and I need to be near, that I'm ready for that. And then I would also make sure that I have all my own things set up. Very often, clients in the medicine, they will not talk to me, and so I might have a Kindle or a book there to read while they are in session. I strongly discourage people being on their phones if you're studying for somebody that's in the medicine. We need to be available to attend to a client, and we have a responsibility to attend to the client while they're in the medicine. And so it's important to have a notepad available so that you can take notes for a client, because a client cannot often take notes for themselves. But I will often provide notepads for clients or journals for clients when they're done. I could see that in the chat there are a few messages about playlists. This is some of the this is some of the work that we do as psychedelic therapists ahead of time, right? And there are playlists readily available on Spotify. There are also playlists that are available from like the MAPS program has their playlists that they use for their MDMA research available. Johns Hopkins has playlists that they had available on Spotify. So those are playlists that are readily available if you just search on Spotify for those playlists. I always encourage a provider to listen to the playlist before they play it for a client to make sure that it doesn't have some of the things that we talked about, right? Like you don't want it to have any language that the client speaks, so that they can have a more internal experience. And so things that are thoughtful to have in session, and there are things that are in this session, in this photograph. Flowers. I bring fresh flowers for clients that are having a ketamine session. It's a nice thing to look at when they come out of the medicine, to have fresh flowers or to have pretty things in the room. Or we might encourage a client to bring something that's meaningful for them to set on the table nearby when they're in a session. I provide them with notepads, blankets, eye shades, headphones, often electrolytes and water. You know, what are we as therapists? We don't have many tissue boxes around our office, so there's often lots of tissues. And then a place for the patient to get sick if they need to get sick. Um, Also drawing and coloring materials. Sometimes when people come out of the medicine, they don't really have the words, as I had said earlier. And so having some drawing or coloring materials can be a way to start the integration process and to let the client emerge gently into sharing their experience with you in a nonverbal way. And then once they are out of the medicine, sometimes it's really important to give the clients snacks because they didn't eat for several hours and then they were in the medicine. And so by now it's probably 3 or 4 hours that they haven't eaten. So sometimes just having something nourishing for the client, such as snacks, very often they won't feel like eating, but sometimes they will. And it's good to have some of these things available for them. And then I always ask for emergency contact number for a client before they go into any medicine experience. It's important to have that for their ride home, or like to find out what their ride is going to be if it's not the same person as their emergency contact. Shelley, do you want to take a minute and ask me any questions that are coming up in the chat?
There are a number of questions. I'm
Okay.
wondering, maybe when we switch over, maybe you could respond to some in the chat.
Okay, we
How
could do
would
that.
be? Yeah, let's try that. And then at the end, if we need to come back to some, we can do that as well.
Excellent. Okay. And we're to our next slide. And so we're going to start to talk about the research on ketamine-assisted psychotherapy. Um, uh, ketamine is FDA approved, and because it's FDA approved, there's less motivation for research. We're not seeing as much research. And so we'll look at some of the reviews and look at diagnosis-specific research as we go on. There's a range of diagnoses and patient demographics and multiple routes and frequencies of administration in the research that we've looked at. There's various models of psychotherapy integration and varying research models for the research on ketamine-assisted psychotherapy. And some of the challenges in the research is that there isn't a standardized methodology for delivering CAP services. Like I said earlier, the FDA doesn't even demand that a therapist be present for ketamine-assisted psychotherapy sessions. And so, it's not what the guidelines aren't very clear on how to deliver services. And so that creates some challenges. So as we get to the next slide, we're going to talk about some literature reviews. And this first one that we're going to be talking about here, y'all bear with me. It's from Druds et al. I think that's how you say it. And in this article, there was various routes of administration, dosing, and number of psychotherapy sessions in the research. They reviewed 17 articles and abstracts involving 603 participants that were identified and reviewed. 7 articles reported randomized controlled trials, and 5 articles were case studies or case series. 4 were open label trials, and 1 was a retrospective study. The results showed a significant decreases in anxiety and depression scores as measured by the Hamilton Anxiety Scale and the Beck Depression Inventory. The most significant improvements were seen in those with developmental trauma or complex PTSD, severe depression, and those who received more ketamine-assisted psychotherapy sessions versus ketamine alone. So yay for us. The more we do ketamine-assisted psychotherapy, the better the clients are getting. So in the treatment of substance dependence, the integration of ketamine and psychotherapy appears to promote abstinence, initiation, improve relapse prevention, improve craving, reactivity management, and increase motivations to terminate drug use in select individuals. Variability in study design, intervention structure, patient diagnosis, and outcome measurement, along with small sample sizes, limit firm conclusions. All right, next. So, additional considerations noted in the literature. In this Adarka et al. In 2012, it said that reported increases in treatment engagement have also been observed and attributed to such sudden gains, as rapid reductions in depression and anxiety have been associated with lower dropout rates and increased participation in therapy. And, so that's great news that the ketamine created a greater capacity for the clients to engage in the therapy process. And the more clients engaged in therapy, the better the outcomes are going to be. So increased engagement, lower dropout rates. And then additionally, the transpersonal nature of ketamine experience can address all aspects of the body, mind, and spirit, and all at the same time. Very often our clients are having a spiritual experience when they're in the medicine, and those spiritual experiences can be very healing for our clients, especially those who have depression. So, overall, it appears that higher doses of ketamine, which bring about those more mystical, transpersonal, or spiritual experiences, can create greater outcomes. More frequent CAP sessions and longer durations of psychotherapy increase the efficacy and durability of improvements with patients with a range of disorders. And so the next review that we looked at was one by Walsh et al. In 2022. And basically that said that there's a need to extend the benefits of ketamine. So there are 83 published reports in this systematic review, comprising 33 systematic reviews, of which 17 included meta-analysis, 29 randomized controlled trials, 2 randomized controlled trials with no placebo, 3 randomized controlled trials with controls, 6 open label trials, and 10 retrospective reviews. IV is the most widely used in clinical settings for bioavailability, reminding you that it's 100% bioavailable, and to control the dose. But other routes of administration have clear practical advantages for client comfort and repeated dosing. And we're talking about client comfort. I mean, it's more comfortable for the client if they are not laying on your couch with a needle stuck in their arm while they're having this emotional experience. So pain can be, or discomfort can be, one of the factors there. Studies that have compared modes of administration or routes of administration have generally not reported meaningful differences in the efficacy. So, what we're saying there is that no matter how you take the ketamine, generally it's going to produce some efficacious results. So ketamine effects in depression generally last from a few days to 2 weeks. So repeated dosing is usually necessary to extend recovery. Again, we want to extend the benefits of ketamine. In general, further empirical work is required to confidently assert an optimal model of ketamine administration. Next.
So I'm going to move into some of the current research on the treatment of mental health disorders. And before I get into that, I want to point out some of the limitations that we face in this research. Some of that, what Tammy covered, that a lot of times the research is looking only at ketamine administration and not in conjunction with psychotherapy. We have some real limitations about what the amount of research that's available that's based on actually therapy with the ketamine. A lot of the study design is not really great. There's some concern about that because ketamine is already FDA approved. There's not a need to prove its efficacy to have it available. So the study design has not generally been great. And another limitation that I want to spend some time on is the underrepresentation of BIPOC populations. This is a limitation often of our research in general in the field of psychology, and definitely in psychedelic research has gotten some attention as a real problem since we're actually taking substances that have been traditionally used in indigenous populations under the circumstances that they have taught us, and yet they're not well represented in the clinical trials. So I looked at this study by Michaels and colleagues, where their aim really was to look at what are the demographics of ketamine research, the trials that are going on. And so in order to look at those demographics, they decided to look at the best designed trials out there in hopes that they did show better representation. So they looked at only double-blind, placebo-controlled, randomized ketamine trials between the years of 1993 and 2020. And they found 31 studies that would actually fit those parameters. And of those, 21 did not even report demographic data, so they couldn't use those. So they had 10 studies that they worked with and found that in those 10 studies, which was about, let me see how many people, 380 participants, the white participants were slightly oversampled, but every category of BIPOC population was underrepresented. Blacks were 9% of the trials, though they're over 12% of the population. The Latinx Hispanic population was only 5% of trials, where they're over 16% of the population, and Asian Americans made up less than 1% of the research, even though they're almost 5% of our population. And unfortunately, mixed race and indigenous populations were not reported at all. So what they point out from this is in spite of the decision by NIH in the 1993 Revitalization Act to require equal representation of women and ethno-racial groups in research. And unfortunately, of these 10 studies, 8 were funded by NIH and still underrepresented these groups. And they also pointed out that in BIPOC populations, especially with major depressive disorders, the symptoms are generally more severe and create more disability in the BIPOC, especially Black Americans. And so there's a particular need for some new paradigms and ways of disseminating that information. Of course, we know there may be fears in BIPOC populations about drug use due to the war on drugs and the consequences of that, incarcerating unfairly marginalized populations, and also the understandable distrust of researchers because of some of the atrocities that have been inflicted on vulnerable populations in the past. So they really put it on the researchers to find ways to collaborate with community leaders and members to improve recruitment. So we have a better understanding of how, in this case, particularly ketamine, can be used in these populations. And then a few more studies that address this. This first study by Vigna and colleagues specifically looked at Black Americans and from a psychedelic use. And so we'll incorporate that into our understanding of how it impacts ketamine use. That they, in their research, found that Black Americans actually do benefit less from psychedelic use or ketamine trials than white individuals. And they understand this as, you know, Tammy talked about the importance of set and setting in the outcome of these treatments. And so if someone is coming in to a ketamine session with a greater number of stressors, just even within that day, even getting to session, returning, knowing they're going to return to more discrimination or stress. Perhaps there's a mismatch with the therapist as far as could be many things, but in this study, they were looking at race, some maybe cultural misattunement in the setting can really impact how much they benefit. And so as therapists, we really need to be thoughtful about these factors and considering what our clients are bringing in, how we can really best prepare them, how we can make sure that we're the best fit for that particular client. This second study by this group of researchers in 2024, really recent, they took it was a small group of people that they interviewed shortly after, within a day or two after their ketamine session, to look at themes that might be prominent in a very diverse sample. So they looked at people who had intersecting marginalized identities in the areas of sexual orientation, gender, education, race, ethnicity, education level, and looked at their reflection on their ability to take something meaningful from that. These sessions were offered at a very low fee to people who would not have been able to afford ketamine treatment. And still, they reflected on how difficult financially it was, because there is the need to have a medical clearance, to pay for extra time in therapy, to pay for the medicine itself. There were just even limitations as far as transportation. They had to get there, they had to find a ride home somehow. Often also, they pointed out the sometimes feeling a mismatch with the therapist, and that could have been in regards to sexual orientation or race, or also just cultural pieces of the treatment itself that didn't feel especially helpful to them or attuned to their needs and experiences. So we want to be thoughtful about preparing people, even providing more information about what's available so that clients can make informed decisions about whether this is a good treatment for them. And we also need more research on how to best fit ketamine treatment to different populations. This article at the bottom by George and colleagues talks about the limitations of a white dominant medical framework. We're really taking indigenous practices and substances and putting them into a very different paradigm in an individual-centered Western approach, and that sometimes just doesn't fit the unique traumas, the stressors that impact many of the populations that we serve. And so these are things that the psychedelic field in overall is having to think about and work with and make progress with, and certainly in ketamine treatment, we have to keep these things in mind. So with all of those limitations in mind, I'll review what we know about ketamine with some specific diagnoses, and also keeping in mind, I'm having to look specifically just at ketamine with different diagnoses, and where it's available, I'll talk more about psychotherapy in addition to ketamine and what we know about that. So we'll look first at depression. And depression is one of the areas where we have the most research. There are just at this point, many even randomized controlled trials looking at the efficacy of ketamine for depression. And there's overwhelming evidence that ketamine is effective in reducing depression, at least for the short term. For some people, it it can remit depression. It can last for many weeks. For many people, it can reduce symptoms for usually around 2 to 4 weeks, and then there is often a need for another administration. And that's the space where we want to keep working with therapy to spread the benefit of ketamine, really use that window of plasticity to stretch that benefit so people don't need multiple administrations. So there are lots of studies here. You'll have all the references in your slides. You can look at these in the future if you want. On the bottom left are reviews looking specifically at esketamine. It's FDA approved. It's been shown to be effective, particularly for treatment-resistant depression. Back in 2015, there was a meta-analysis that showed the efficacy of ketamine for both unipolar and bipolar depression. And more recently, in 2020, we see there are many more randomized controlled trials looking at a sort of heterogeneous group of depressive disorders treated with multiple routes of administration. And they felt that the efficacy of ketamine for treatment-resistant depression was established. There's, so much evidence of that. Then this article by Christ at the bottom really looks more specifically at repeated administrations to see does it remain effective when it's administered more than one time? And they found that it is over multiple administrations. It continues to have a positive impact on depression. And they also noted, which shows up throughout the research, that there seems to be a somewhat independent effect of ketamine on suicidal thinking and depression. They're not always affected equally or to the same level. And so it's likely that ketamine is working in multiple channels on these two particular symptom clusters. We'll talk more about that. And then what about its effectiveness? We know that in clinical trials, lots of things are screened out. So what about when we actually just go out in the world and we do ketamine work and, is it still effective? And this study by Al-Nafisi and colleagues looked at many studies, over almost 2,700 clients. And this was through chart reviews, case studies, retrospectively looking backward at a heterogeneous group of depressive disorders. So treatment-resistant depression was present, and also other levels of depression. They found that ketamine was significantly effective in working with treatment-resistant depression across repeated treatments. So we know that we can continue to provide ketamine and get benefit from that. And that people vary in the magnitude of effect to them. And when we look at response rates, a response rate for depression means that there's at least or over 50% improvement in depression symptoms based on whatever measure was used in that study. And we see that people had up to 55% response rate, which is really great. You think at least many of these people have treatment-resistant depression and are having a significant reduction in their depressive symptoms. And even up to 36% had remission. That's really optimistic. I mean, that's a really wonderful thing for us to think about. And I wanted to, put in one study did show some worsening of symptoms, and that is really not frequent in the literature. That's an unusual occurrence. And they found a less consistent but clinically significant anti-suicidal effect. So often what we see with many disorders is that if um, there's significant depression, the depression will improve more than some of the other symptoms. And just looking at bipolar depression, I know there can be some concern about how ketamine might affect people with bipolar disorder. Um, there's clear indication that bipolar depression can be really effectively treated with ketamine. In this first study with IV ketamine, 61% of participants achieved a response. The same in the second, there was a good response to ketamine. And then as far as effectiveness, in a community clinic that treated bipolar 1 and 2, they found statistically significant and clinically significant antidepressant effects. And as Tammy mentioned earlier, sometimes there are some symptoms of mania that show up, usually some hyperverbal behavior or some agitation. And at least what's reported in the literature is that that generally diminishes within 2 to 24 hours. It doesn't remain an issue. And as far as suicidal thoughts and behaviors, I just chose one review here to talk about, to kind of sum up what we know about suicidality and ketamine. In this study, they looked at 26 total studies that either had the primary purpose of looking at suicidal thoughts, or that was the secondary purpose of the study. So it was an important part of the study. And they found compelling evidence for the short-term benefit with IV ketamine, but interestingly not intranasal. And again, we run into this issue of short-term benefit that we want to really work. That's really what we want in ketamine-assisted psychotherapy, is to stretch out that benefit by working with this window of openness. There was a full remission in 30 to 60% of cases after just one infusion. And that was measured generally after 3 days, looking at the remission level. And it didn't matter what type of depression they were looking at. And the authors just caution that we want to remember that ketamine treatment is just one part of a multimodal approach to working with suicidal thoughts. We don't want to think that that's going to be the solution, but it is a helpful part of treatment for suicidality.
Shelley, in this study, is it for ketamine-assisted psychotherapy or just ketamine?
This particular study right here was just ketamine. Yeah. So this was most likely people who had, I would say the majority of the people had been admitted to a hospital and given an IV infusion of ketamine to help with suicidality, and were measured at that point.
Thank you.
Thank you. So to look at, as we're looking at depression and we want to think about, like, what would it mean to do PAP with depression? And we want more research in this area so we have more information about this. There is this researcher, this was the second study they did specifically with CBT and ketamine. The first was just a pilot study. This one, they had a fairly small sample with treatment-resistant depression. We want to remember that. These are people who have really suffered and haven't found much hope in treatment. After 3 weeks of twice-weekly IV sessions, they waited until after all the administrations to start CBT and only treated the responders, which were randomized to treatment as usual in CBT for another 14 weeks. And 2/3 of the people had response, which is, that in itself is really helpful. And they did find that there was a greater sustained improvement in the CBT group. So that's, there's reason for optimism there, that as we continue to work with the combination, especially of evidence-based treatments with ketamine, how we might be able to extend these timeframes. So I want to look at PTSD. This was really the second major disorder that I want to talk about as far as what the research shows. And we'll find a lot of mixed results as we look at the research around this particular disorder. This research group, in their review, found this was 6 studies, about 220 participants. And I just want to point out, other than depression, we just don't have large numbers of research studies to look at. So if you're interested in research and you're interested in ketamine, we need more research. So the reviews we're looking at will cover fairly small numbers of studies. But what they did find was that the effect of ketamine compared to controls was pretty weak. And when you factor in the trial bias, the problems with the studies themselves, there was no significant difference. And often, and what we find is that there are discrepancies between the reports of clinician reported change in clients and their own reports. So often maybe the clinicians will use the CAPS-5 interview for outcomes, the clients will use the PCL-5, and one group will report improvement, but not the other, and it's not always the same. And they suggest that future studies use controls that are maybe better than what was used in these studies, and the confounding piece of psychotherapy, which is always difficult to measure because how much does the alliance play into the change? Something that they pointed out that I think is really helpful for us to look at for the future in working with PTSD and ketamine is just the heterogeneous presentations of people with PTSD or even complex PTSD, all the more so that because of these many symptom clusters that we're working with, people can have higher levels of disturbance in one cluster than another. And so the way that ketamine is working on those different symptoms varies. And, we think about especially depression, if ketamine is making improvements in depressive symptoms, that cluster may see some reduction in symptoms for people who especially suffer in that cluster. So they suggest that rather than looking at the whole diagnosis or a outcome measure that looks only at all the symptom clusters, that we pick some specific markers and measure change in those maybe symptom clusters or symptoms themselves. Another systematic review that's really recent, 5 randomized controls with the primary diagnosis of PTSD. We see that they had fairly high levels on the PCL-5. And although there was improvement, it was not clinically significant. They did note that there were it didn't exacerbate the PTSD. It didn't, bring in any psychotic or manic symptoms. But some mixed reviews here. And so I wanted to look at a couple of studies that were reviewed in some of these reviews. And unfortunately, in the area of PTSD, more than any other disorder, this researcher and the one I'll look at next have a number of conflicts of interest. And so they both have patents for ketamine-related products, and they are consultants for pharmaceutical companies. So that's not to negate their research, but we have to hold that, in mind as we look at the results. And in this study, Fetter and colleagues found really great results. Their CAPS-5 scores were significantly lower in the ketamine group than in the control at both week 1 and week 2. And many more participants in the ketamine group attained response, which for PTSD is a 30% reduction from baseline compared to control. And the MATTERS scores, that is a measure of depression, and they saw a significant improvement in that. We will consistently see that. When studies measure depression as well as other diagnoses, there will consistently be improvement in depressive symptoms. This study, again, this researcher has some conflicts of interest, double-blind, randomized, placebo-controlled, multi-center, well-designed study found no significant effect on PTSD. PCL-5 scores improved over time for everyone, all the participants. And in this was an interesting study because there was the standard high dose of ketamine, and then they gave them a lower subclinical dose of ketamine and a control, which was not psychoactive at all, in hopes of blinding people so they wouldn't necessarily know whether they got the standard dose or not. And they found that over the course of the whole treatment, there was improvement, especially in depression, for all of the people who took ketamine at any dose. And repeated dose were well tolerated. So we see, again, mixed results with PTSD. And I want to look at, there are actually, in those reviews, there are actually 4 studies with PTSD that looked at some ketamine-assisted psychotherapy approaches to see if that might be effective. And we see some really promising results in this area. So in this first study with prolonged exposure in ketamine, they did see significant changes in all measures, PCL-5, the depression measure matters, and the CAPS-5. After they controlled for the changes in depression, they still found changes in the PCL total score and the avoidance cluster. And we do know that ketamine does reduce the activity of the amygdala, as do other psychedelics. And so that can be really helpful as people are working with trauma. They're able to be present with some difficult material that comes up, be exposed to that and work with that in the integration sessions. This offered 3 sessions. It was measured after 3 sessions post-ketamine. And then people were also offered an additional 7 sessions if they wanted to continue with the PE treatment, and saw continued progress with that. This next study by Dames and colleagues, I hope you'll read it. I hope you'll go to the references and find this study and read it, because I feel like it is the embodiment of what we want to do in CAP treatment. This was CAP provided for healthcare providers who had PTSD and depression after COVID-19. It was a study done in Canada. And what I love so much about it is that they really modeled all the elements of CAP that are so important. They had an interdisciplinary team, multi-agency. They brought in Indigenous knowledge holders, some cultural safety experts. They did training in trauma-informed practices, and had a combination over 12 weeks of group sessions with ketamine and individual sessions with ketamine, and just found really amazing results from that. And I know that, there's so much happening there that it's hard for us to say what was the effect of ketamine on that. But this is what we want to have happen with ketamine, to have this opening, this shift in consciousness that allows more openness, more possibility, and especially in community, to be able to learn in community and heal in community. And you see that they had just amazing results in the areas of anxiety, depression, PTSD, and work-life functioning. And finally, here's another group of researchers in the PTSD world who are using their own approach to therapy called mindfulness-based extinction and reconsolidation. And I won't read through all of this, but basically they did 2 arms with responders, and one group got ketamine, one did treatment as usual, placebo treatment. And they found that the group that had ketamine treatment was able to have no PTSD symptoms or minimal PTSD symptoms for over 30 days, which is much longer than with mindfulness alone or with even just a ketamine infusion itself. So we see really promising results here. Of course, we need more well-designed studies, bigger sample sizes, but people really trying to work with and create the circumstances that we want in CAP to capitalize on what ketamine brings to the treatment. And then I'll talk briefly about substance use disorders, OCD, and anxiety. Even though there's a long history of working with substance abuse with ketamine, the actual studies themselves are not very well designed and don't allow us to make many conclusions. So none of these areas really have much research, but I'll share what we do have. So in these two studies, they were looking at substance use disorder. Primarily, the studies look at alcohol use disorder, but there were some that looked at also cocaine use disorder and opiate use disorder. And consistently, and I think the research suggests that maybe ketamine is working through different neurotransmitter channels with substance use disorder than it is with depression, potentially, because it really has some significant impact on people's ability to maintain abstinence and a decrease in cravings after treatments versus controls. And we find that people who have a mystical experience in their ketamine treatment do often report that that has really helped in reducing their use. We find that in the psychedelic world, where the research shows that when there is a more, sometimes much more challenging psychoactive experience in the long term, it leads to more significant change. It also seems to help with alcohol withdrawal syndrome. So again, there's no conclusion to be drawn, but perhaps ketamine is working in the opiate neurotransmitter system there in some way to help with this. And we see in the second study some promising evidence that integrating mindfulness-based and motivational therapies, these things that are so helpful in substance use disorder, can help sustain abstinence, even up to a year. They're looking at follow-ups over a year and still seeing good results. With OCD, we have very limited information to work with, but we see some of the same problems that we do with ketamine in general. There's significant improvement, but it's short lasting. And so studies that are looking at, you see in the second study there, 10 sessions of exposure-based CBT to help work with the OCD are having, mixed results right now. But when there's comorbid depression, the depression does improve. And anxiety, again, significant results immediately, pretty short-lived. We see mostly improvements in irritability and panic rather than generalized anxiety. Okay, move on. Tammy, I think you're muted, perhaps.
Perhaps I am.
There.
All right. We're going to skip through this slide. Let's go to the next one, Shelley, in the interest of time. So if you decide you want to pursue a CAP training, some focus on ketamine-assisted psychotherapy alone, whereas, and those are, they tend to be fairly short and need supplemental work. And some focused on psychedelics in general, like the program that Shelley and I went through. They have more detail and also tend to share other areas that you might want to be trained in the future as the legal landscape changes in our country. It is recommended that you look for a training that is at least a several months to a year long and includes in-person practicum experiences. Next. So here we're going to, we're looking at the two major programs that are available that are for psychedelics generally. Both of these programs cover ketamine-assisted psychotherapy, as well as MDMA and psilocybin. Both programs are based out of Boulder, Colorado. There's a difference in cost in those programs. For the IPI program, it's $10,000 for the program, $3,000 for the psilocybin practicum, where you go to Eugene, Oregon, and have a practicum experience, and $1,500 for the ketamine practicum is additional, and that is where you go to Boulder, Colorado, to the treatment facility in Boulder and have a practicum experience. This program is 256 hours of learning with 80 continuing education credits. It's advertised as a one-year training, but it's just short of 1 year. For example, they are about to start a program that's starting in July, middle of July, and will finish up in May. In this program, it's a postgraduate training certificate. So when you graduate from this program, you're a certified psychedelic assisted therapy provider from IPI. It's 90% live virtual learning. It has optional in-person ketamine training practicum, which I talked about, and the optional in-person psilocybin training practicum. And it also has an optional MAPS intensive weekend MAPS, Public Benefit Corporation, or LICOS training. And both of these programs are the only programs that offer the MAPS training at this time, as MDMA is pursuing its FDA approval. MDMA-assisted therapy is pursuing FDA approval. So with the Naropa program, it's already closed for 2024. They won't be taking new students until next year. It's 150 hours of virtual learning. It's not just for clinicians, but also available for Native American, Indigenous people, acupuncturists, lawyers, other professionals. And it has a postgraduate training certificate. Both programs offer justice, equity, diversity, and inclusion material in their coursework. And a question came up about Utah's Senate Bill 266. And it's our understanding that if you got trained in one of these two programs with Utah Senate Bill 266, you would have to work in a hospital setting or a university setting. Next. So these next trainings that we cover are trainings that are specific to ketamine-assisted psychotherapy, or the business of ketamine-assisted psychotherapy. So Alchemy Community Therapy Center is in Oakland, California. It's $2,100. It's a 7-week program. It is 36 virtual hours with no practicum experience. I'm kind of partial. I think you're going to want a practical experience. You're going to want to know what it's like to sit for somebody in the medicine. And so just take that in mind. Fluence is out of New York City, New York. It's $2,500. It's a 6-week program, live online training with no practicum. Polaris Insight Center is out of San Francisco, California. It's $2,724 for that training. The virtual model has 6 modules. It's 48 hours. It also has 3 advanced modules for $1,362 with special topics series, including ethics, integration, ACT, music, and healing the healer. Prati, or the Psychedelic Research and Training Institute, is based in Fort Collins, Colorado. It's $3,300 for clinicians and $4,750 for prescribers. It's an in-person training that is 4 days of practicum included. And it also has a business of psychedelic medicine training. So for those of you who are wanting to make this like your primary business, there's a course that helps with that. Those two workshops are $299 and $249. And then there's a group ketamine-assisted psychotherapy workshop, which is a 5-day workshop for $3,400. Roots to Thrive is in Vancouver, British Columbia. Their program is $3,500. Basic level of training in psychedelic medicine plus 2 years clinical experience required. 52-hour hybrid training with 4 days in person in Vancouver Island, British Columbia. So for a lot of these trainings, you're going to have to travel for the practicum experience. And generally, they're going to run you $2,000 to $3,000. All right, next. Then the final two training programs for psychedelic ketamine-assisted psychotherapy are Living Medicine Institute in Asheville, North Carolina. They have a CAP retreat that is $3,200. It's a 3-day retreat and has a practicum experience that involves 2 different routes of administration. So you can see what it feels like to have 2 different experiences. They have a level 1 training that is $6,000, which is a 16-week intensive online that includes 7 experiential sessions. And for those, you're going to have to travel. And then the Ketamine Training Center in Phoenicia, New York is $3,000 for a therapist and $3,500 for prescribers. And that covers the fundamentals of CAP. It's a 5 to 6 day training with an in-person experiential and has scholarships for BIPOC students. And so this picture I wanted to include in here because it gives a really good a good impression of what it's going to be like for some of these trainings that you would attend in person in the practicum experiences. So this photo is from Living Medicine Institute, and it just shows that there are, many mattresses placed in a very large room with chairs sitting next to them for the sitters. And so basically when you're in these trainings and you participate in the medicine, you will be laying on one of the mats or the beds on the floor and have a pillow and a blanket, and then a person sitting next to you. And usually you have facilitators in the room or monitoring with cameras. And so that's very much what it looks like to have a group medicine experience. And so I thought that that would be good for your learning or understanding. Next. So ketamine offers both the potential to more effectively treat those suffering and a catalyst for profound and much needed shift in paradigm of mental health care. I thought that was a pretty profound statement and a good way to kind of start to close this out. Although we do have a slide that comes up next that's talking about resources. And this will be in your materials that you receive after this presentation. And then we have one more slide where we're like, oh yeah, let's talk about palliative care. And when we talk about palliative care, Shelley, I don't know if you want to talk about this, but I wanted to add a little 2 cents of like, one of the most delightful human beings that we came across in our training at IPI was Dr. Rohini. And Dr. Rohini is offering a palliative care specific, a ketamine-assisted psychotherapy training that's specific to palliative care. Unfortunately, to attend this program, you have to be trained in CAP already, but it's an 8-week immersive course and it's $3,000. And so for those of you who are curious, and this is your area of study, Dr. Rahini is a delightful human being, and you would really benefit if you're already trained in one of these modalities.
Yeah, we wanted to respond to this because there was a question with registrations about ketamine's use with palliative care, and There's not a lot of research around this, but it does seem to help with depression and anxiety. It won't get rid of it, but it does reduce some of the more severe experiences of that. And yes, I think that training would be really wonderful for anybody who's in a place to be able to participate in that.
Because that training is Dr. Heaney's primary focus and practice is in hospice work, and so she's going to speak to using her clinical experience and her heart for really working with people in end of life care and how beneficial psychedelics can be, and ketamine specifically can be for people that are in end of life.
Yeah. Okay, we have reached the end of our time together. You will get the slides. We've put all of our references in the slides for you to look at in the future. You'll have all those resources. Thank you all for your attention.